In this section, we'll look at the musculoskeletal structures that surround the abdomen. We'll look first at the bones that lie above, behind, and below the abdominal cavity. Then we'll see the layers of muscle and tendon that form the wall of the abdomen. After that, we'll take a detailed look at the lowest part of the abdominal wall, the inguinal region. Lastly, we'll look at the principal blood vessels and nerves of the region. We'll look at the abdomen in this tape as a container, as we did with the thorax. We'll look at what it contains in Volume 5 of this atlas. Let's start with the bones that we're concerned with: the lower ribs, the lumbar vertebrae, and the bones of the pelvis. We're familiar with the rib cage already. The lower edge of the rib cage, formed by the last three ribs and the costal arch, is called the costal margin. Just above the costal margin on the inside, the diaphragm arises, as we've already seen. The diaphragm forms the upper limit of the abdominal cavity. Because of the shape of the diaphragm, the upper part of the abdominal cavity extends a long way above the costal margin. The rib cage is also a major site of attachment for abdominal wall muscles, as we began to see in the last section. The lumbar vertebrae provide the foundation for the posterior part of the abdominal wall. The massive bodies of the vertebrae project forward into the abdominal cavity. Next, we'll take a further look at the bones of the pelvis. For a start, we need to understand something about the word pelvis. The pelvis is commonly used as the short name for two different things: the bony pelvis and the pelvic cavity. This is the bony pelvis, consisting of the sacrum and the two hip bones. This is the pelvic cavity. It's the deep and narrow space that's enclosed by the sacrum, the lower parts of the hip bones, and by ligaments and muscles that we'll see in the next section. The pelvic cavity is continuous with the abdominal cavity here, at the pelvic brim, which we'll return to in a minute. To understand the abdomen, we need to understand the upper and anterior parts of the bony pelvis. We took a good look at the sacrum in the first section of this tape. The only parts of it that we'll mention here are the most anterior part, the promontory, and this broad part, the ala, or wing of the sacrum. Now we need to take a look at some important features of the hip bone. The hip bone is also known as the innominate bone. It develops by the fusion of three originally separate bones: the massive ischium below and behind, the more lightly constructed pubis below and in front, and the broad ilium above. We'll look at the ilium first. The thick lower part of the ilium is the body. The broad expanse of bone that fans out above the body is the ala, or wing of the ilium. The concavity on the inner surface of the ala is known as the iliac fossa. This roughened area, the auricular surface, articulates with the sacrum, forming the sacroiliac joint. The broad roughened edge of the ala of the ilium is the iliac crest. The iliac crest ends behind at the posterior superior iliac spine. It ends in front at this important projection, the anterior superior iliac spine. The iliac crest lies close to the surface all the way along its length. The anterior superior iliac spine is here. Next, we'll look at the pubis. This is the superior pubic ramus. This is the body of the pubis, and this is the ischiopubic ramus. This thick ridge is the pubic crest, which ends at this prominence, the pubic tubercle. Lateral to the tubercle, the superior ramus of the pubis has a sharp upper border called the pecten. The two hip bones are held together in front by a cartilaginous joint, the pubic symphysis. The front of the pubic symphysis is here. The pelvic brim, the narrowing which forms the open end of the pelvic cavity, is made up by the pubic symphysis in front, by the promontory of the sacrum behind, and on each side by the ala of the sacrum, this shoulder on the body of the ilium called the arcuate line, and by the superior ramus of the pubis. The parts of the bony pelvis that lie below the pelvic brim, the ischium and the ischiopubic ramus, don't concern us at present. We'll look at them in the next section. As we've looked at the features of the bony pelvis, we've been seeing them in the position they're in when we're standing upright. It's useful to keep in mind certain basic planes and angles. In the normal standing position, the anterior superior iliac spines and the front of the pubic symphysis are in the same vertical plane when seen from the side. The plane of the pelvic brim is tilted at about 60 degrees to the horizontal. The pelvic surface of the sacrum slopes at 30 degrees to the horizontal. The pubic symphysis is tilted at almost the same angle. It's also useful to keep in mind the distance between the costal margin above and the pelvis below, and the way that distance changes from the front to the side. In front, it's a long way from the xiphoid process down to the pubic symphysis. But at the side, the costal margin and the iliac crest are only this far apart. Now let's review what we've seen of the bones of the abdominal region. Here's the costal margin. Here are the lumbar vertebrae. Here's the ilium, the body of the ilium, the wing of the ilium, the iliac fossa, the iliac crest, the anterior superior iliac spine. Here's the pubis with the superior pubic ramus, the body of the pubis, the ischiopubic ramus, the pubic crest, the pubic tubercle, the pecten, and the pubic symphysis. Before we look at the muscles, there's one important structure that we need to add to the picture, the inguinal ligament. Here's the inguinal ligament. It's a strong band of tendinous tissue that goes from the anterior superior iliac spine to the pubic tubercle. There's a gap between the inguinal ligament and the underlying bone. Through this gap, some important structures pass from the abdomen to the thigh, including the femoral vein, artery, and nerve medially, and the belly of the psoas and iliacus muscles laterally. The inguinal ligament isn't an isolated structure. As we'll see, it's the lowest part of the external oblique aponeurosis, which is the outermost of the muscular and tendinous layers of the anterior abdominal wall. Now, we'll move on to look at the muscles that make up the wall that surrounds the abdominal cavity. We'll begin with the muscles which, along with the vertebral column and the diaphragm, form the posterior part of the abdominal wall. We'll look at the erector spinae muscles and their surrounding fascia, then at quadratus lumborum, then at psoas major and iliacus. We're looking from behind. Here's the iliac crest, here's the 12th rib, here's the midline. Here are the muscles known collectively as the erector spinae. We looked at them in the first section of this tape. They arise from the sacrum and from this part of the iliac crest. They're inserted on the thoracic vertebrae and on the backs of the ribs. The erector spinae muscles are enclosed on the front and on the back by this envelope of tendinous tissue called the thoracolumbar fascia. The layer on the back of the erector spinae arises from the spinous processes. The layer on the front arises from the transverse processes. The two layers of thoracolumbar fascia fuse into one thick layer along the border of erector spinae. The thoracolumbar fascia is an important attachment for muscles of the abdominal wall, as we'll see shortly. Next, we'll add quadratus lumborum to the picture. Here's quadratus lumborum. It lies in front of the erector spinae muscles and their investing fascia. Quadratus lumborum arises from the 12th rib and the transverse processes of the upper three lumbar vertebrae. It's inserted on the most medial part of the iliac crest and the transverse process of L5. Quadratus lumborum assists in producing lateral flexion of the lumbar spine. Lying medial to quadratus lumborum is psoas major. Psoas major arises from the transverse processes, vertebral bodies, and intervertebral discs from T12 to L5. It runs down across the alar of the sacrum, across the sacroiliac joint, and along the pelvic brim. Before seeing where psoas major goes, we'll add its close neighbor, iliacus, to the picture. Here's the iliacus muscle. It fills the iliac fossa. Iliacus arises from this wide area on the wing of the ilium. Down here, the medial fibers of iliacus and the lateral fibers of psoas major join, forming a single muscle belly known as the iliopsoas. The iliopsoas runs beneath the inguinal ligament and passes backwards to insert here on the lesser trochanter of the femur. As they slope downward and forward toward the inguinal ligament, the iliacus and psoas muscles are covered by this layer of dense connective tissue, the iliacus fascia, which we'll meet when we look at the inguinal ligament. This is just the lower part of it. The iliacus fascia is covered in turn by the membrane which lines the abdominal cavity, the peritoneum. This is a preview of the peritoneum. We'll see it more fully later in this section. When we're looking at the abdomen, we tend to see psoas and iliacus as static background structures, but they have an important function. They're the principal muscles that produce flexion at the hip joint. Now that we've looked at the individual muscles, let's take an overall look at the structures that form the posterior abdominal wall. To do that, we'll add the diaphragm to the picture. The steeply rising diaphragm forms the highest part of the abdominal wall, not only at the back, but all around. The diaphragm makes a dome-shaped partition separating the abdominal cavity below from the thoracic cavity above. At the bottom, the middle part of the posterior abdominal wall, formed by the vertebral bodies, becomes continuous with the wall of the pelvic cavity here at the sacral promontory. On each side, the psoas muscle stands away from the vertebral bodies like a pillar. The iliacus muscles, with their investing fascia, form a continuation of the posterior abdominal wall that slopes downward, forward, and inward, ending here at the inguinal ligament. This is the lowest part of the anterior abdominal wall. In this dissection, all the abdominal blood vessels and nerves have been removed, together with most of the peritoneum. We'll add those structures to the picture later in this section. Now, with our focus still on muscles, we'll move on to look at the four muscles which form the great expanse of the lateral and anterior abdominal wall. These muscles fill in the huge gap that's created by the costal margin above, the edge of the thoracolumbar fascia behind, and the iliac crest, the inguinal ligament, and the pubic crest below. First, we'll look at the rectus abdominis, which runs vertically next to the midline from the lower anterior ribs to the pubis. Then we'll look at the three large flat muscles, transversus abdominis, internal oblique, and external oblique. There's a time-honored word that's used in describing the tendons of the flat muscles: aponeurosis. Aponeurosis is a word that's used to describe a tendon that's in the form of a sheet. We'll look at the rectus abdominis muscle first. Here's the rectus abdominis, together with the innermost of the flat muscles, transversus. The rectus abdominis is a very long muscle, wide at the top and tapering to a more narrow attachment at the bottom. It arises from the 5th, 6th, and 7th costal cartilages. It's inserted on the pubic crest. The rectus is divided on the front by these bands of tendon called tendinous intersections. Sometimes there are 3 of them, sometimes 4, as in this case. The intersections go about halfway through the muscle. The action of the rectus muscles is to produce flexion of the lumbar spine. The rectus muscles act in opposition to the erector spinae muscles. Besides producing active flexion, the rectus muscles have an important static effect. They keep the lumbar spine straight at times when the force of gravity tends to extend it. In the intact body, the rectus abdominis is enclosed on the front and on the back by a tendinous envelope that's formed by the aponeuroses of the 3 flat muscles. This is the posterior layer of the rectus sheath. The posterior layer ends here, about 3/4 of the way down the muscle. Sometimes it ends gradually, sometimes abruptly, with a distinct lower border, known as the arcuate line. Below here, there's just a little loose fascia between the back of the rectus and the peritoneum. Now we'll add the anterior layer of the rectus sheath to the picture. The anterior layer extends all the way from the costal margin to the pubis. If we incise the anterior rectus sheath and try to retract it, we can see that it's firmly attached to the tendinous intersections. There's one here, another one here. Here, we've divided those adhesions so that we can retract the anterior rectus sheath medially. The 2 layers of the rectus sheath come together near the midline. Here's the posterior layer. Both layers insert into this dense midline band of tendinous tissue the linea alba. The linea alba extends from the xiphoid process to the pubis. We'll see more of the rectus sheath as we look at the aponeuroses of the 3 flat muscles. We'll look at the flat muscles next. Flat may not be the best word to describe them. In the vertical plane, they're markedly curved, as we'll see. We'll look at all 3 of them, then we'll look at their actions. We'll start with the innermost of the 3 flat muscles, transversus abdominis. Here's transversus abdominis. The fibers of transversus all run in the same transverse direction, except the lowest ones, which run obliquely downwards. Transversus abdominis has a long line of origin, from here to here. At the top, its fibers arise from the inner aspect of the costal margin, from the 6th rib to the 12th. Between the 12th rib and the ilium, transversus arises from the edge of the thoracolumbar fascia. Below, it arises from the inner aspect of the iliac crest. The lowest fibers of transversus arise from the most lateral part of the inguinal ligament. Transversus has a short, free lower border. The muscle fibers of transversus end in this broad sheet of tendon, the transversus aponeurosis. The transversus aponeurosis fuses here with the aponeurosis of the overlying internal oblique muscle to form one aponeurotic layer. Now we'll add the internal oblique muscle to the picture. The internal oblique arises from the thoracolumbar fascia and from the iliac crest. The lowest fibers of the internal oblique arise, like those of transversus, from the lateral part of the inguinal ligament. Like transversus, the internal oblique has a short, free lower border. The internal oblique fans out so that its highest and lowest fibers run in markedly different directions. Back here, the fibers of the internal oblique run steeply upward. Here, they run less steeply. Here, they're transverse. And here, towards the inguinal ligament, they run downward. The highest fibers of the internal oblique insert on the lowest three ribs. Its remaining fibers end in this internal oblique aponeurosis, which, as we noted, fuses on the underside with the transversus aponeurosis. It's also joined on its outer aspect by the external oblique aponeurosis. This is the cut edge of external oblique. From here to here, the combined aponeurotic layer divides at the edge of the rectus into two layers, one passing behind and one in front of the rectus. Below here, the combined layer doesn't divide, but passes entirely in front of the muscle. Now that we've looked at the internal oblique, it's time to add the external oblique muscle to the picture. Here's the external oblique muscle, the outermost of the three flat muscles. The fibers of the external oblique spiral downwards and forwards at the side, downwards and medially in front. The external oblique arises from a broad area on the outside of the rib cage, all the way from here on the 12th rib to here on the 5th rib. The zigzag line of origin of the external oblique fits in with the line of origin of serratus anterior. Though it's all one continuous muscle, we'll look at the external oblique in two parts. A posterior part that arises from the 12th to the 10th ribs, and an anterior part that arises from the 9th to the 6th rib. The anterior part of the external oblique ends in this external oblique aponeurosis. This fuses with the combined aponeuroses of the other two flat muscles to form the anterior rectus sheath. The external oblique aponeurosis has a long, free lower border between the anterior superior iliac spine and the pubic tubercle. As we've seen already, this free lower border is the inguinal ligament, which we'll see in detail shortly. The part of the external oblique that arises from the 10th to the 12th ribs remains fleshy from its origin to its insertion. It inserts along the outer edge of the anterior half of the iliac crest. Here, at the back, the external oblique has a short free border between the 12th rib and the iliac crest. Now that we've looked at all three of the flat muscles, we'll look at their actions. When the three flat muscles on both sides contract together, as they usually do, they raise the pressure inside the abdominal cavity. When our airway is open, the rise in intra-abdominal pressure pushes the diaphragm upwards, causing air to leave the lungs, as we saw in the last section. When we hold our breath by closing our larynx, the flat muscles provide the pressure that's needed to expel the contents of either the rectum, the bladder, or the uterus through their respective openings. When the oblique muscles contract individually, they also play a part in producing lateral flexion of the lumbar spine and rotation of the thoracic spine. Now that we've looked at all the muscles that form the walls of the abdominal cavity, we'll take a look inside the cavity itself. To do that, we'll look at a dissection in which the abdominal organs and the left half of the anterior abdominal wall have been removed. Here's the serous membrane that lines the abdominal cavity, the parietal peritoneum. We'll see it in more detail in Volume 5. Beneath the peritoneum, there's a continuous layer of loose connective tissue. Here, as we've seen, it's called the iliacus fascia. Here, on the inside of the anterior abdominal wall, it's called the transversalis fascia. Now we'll move on to look at the inguinal region. An important feature that we'll see is a structure that passes obliquely through the abdominal wall, just above the inguinal ligament. In the female, the structure is the round ligament of the uterus. In the male, it's the spermatic cord, the lifeline of the testis. The passage that the structure passes through is called the inguinal canal. We'll start by taking a more detailed look at the inguinal ligament. In this dissection, the body has been divided in the midline. Here's the anterior superior iliac spine. Here's the pubic symphysis. Here's the inguinal ligament. It's the lowest part of the external oblique aponeurosis. Laterally, the ligament is attached to the anterior superior iliac spine. Medially, it's attached to the pubic tubercle. The cut edge here was created by dividing the external oblique aponeurosis along this line. The edge of the inguinal ligament can't be seen from the outside because the fascia lata, the investing deep fascia of the thigh, is attached to the ligament along here. To see the edge of the ligament, we'll go round to the inside. Here's the edge of the ligament. The iliacus fascia, which has been removed in this dissection, comes down over the iliopsoas and is attached to the ligament along here. The lowest fibers of the inguinal ligament curl around to form this triangular extension, the lacunar ligament. The lacunar ligament runs backwards and a little upwards to insert on the sharp upper edge of the superior pubic ramus, the pecten. The lateral part of the inguinal ligament gives rise to the lowest fibers of the transversus and internal oblique muscles. Here's transversus. Its lowest fibers arise from about the lateral 1/4 of the inguinal ligament. Now we'll add the internal oblique to the picture. Here it is. The lowest fibers of the internal oblique arise from the lateral 1/3 of the inguinal ligament. The tendinous fibers of these two muscles arch over and unite to form this flat tendon, the conjoint tendon. The conjoint tendon is attached to the pubic crest and also behind to the pecten. Now we'll bring this lowest part of the external oblique aponeurosis up to its natural position and add the rest of the aponeurosis to the picture. Here it is. There's an opening in the external oblique aponeurosis, the superficial inguinal ring. Through this, the spermatic cord, or the round ligament, passes, as we'll see shortly. The fibers below and above the opening are called the inferior crus and the superior crus of the superficial inguinal ring. They're attached to the pubic tubercle and the pubic crest, respectively. The inguinal canal passes through the superficial inguinal ring, then beneath the free borders of the internal oblique muscle and the transversus abdominis muscle. To see where the inguinal canal begins, we'll go round to the inside. It begins at this arch beneath the lower border of transversus, which is called the deep inguinal ring. Now we'll look at the spermatic cord. In the developing embryo, the migrating testis pushes its way through the abdominal wall and into the scrotum, creating the inguinal canal as it does so. The testis drags behind itself its own blood vessels and the vas deferens, and it carries along as a covering a little of each layer that it goes through. To see the result, we'll look at a dissection in which the spermatic cord has been kept intact. Here's the spermatic cord with its outer layers removed. To see the structures that run inside the cord, we'll go round to a rear view again. The deep inguinal ring is here, hidden by the transversalis fascia. The iliacus fascia has been removed. The structures that pass through the deep inguinal ring and into the spermatic cord are the blood vessels to the testis, the testicular artery and vein, and the vas deferens, which passes over the pelvic brim and into the pelvis. Emerging from beneath transversus, the vas deferens and the blood vessels are surrounded by this coating of internal spermatic fascia. Now we'll add the internal oblique muscle. The internal spermatic fascia is surrounded by this layer of muscle, the cremaster muscle. Here's the cut edge of the external oblique aponeurosis. We'll add the rest of the external oblique aponeurosis to the picture. As the cord emerges from the superficial inguinal ring, it lies in front of the pubic tubercle, here. This edge of the superficial ring is a dissection artifact. In reality, it's continuous with the outermost layer of the spermatic cord, the external spermatic fascia. From here, the spermatic cord goes down into the scrotum. We'll look at the testis in volume 5 of this atlas. Now, we're about ready to move on to look at the principal blood vessels and nerves of the abdomen. Before we do that, let's review what we've seen of the muscles and the structures of the inguinal region. Here's the thoracolumbar fascia, quadratus lumborum, psoas major, and iliacus. Here's rectus abdominis, the tendinous intersections, the posterior rectus sheath, the arcuate line, the anterior rectus sheath. Here's transversus abdominis, the internal oblique, and external oblique muscles. Here's the inguinal ligament, the lacunar ligament, the deep inguinal ring, the superficial inguinal ring, and the spermatic cord. Now we'll move on to look at the blood vessels of the abdominal region. First the arteries, then the veins. We'll start by looking at the part of the descending aorta that lies below the diaphragm, the abdominal aorta. Here's the posterior abdominal wall, with the arteries in place and the veins removed. Here's the abdominal aorta. It enters the abdomen by passing through the aortic opening in the diaphragm at the level of the 12th thoracic vertebra. The aorta runs down on the front of the lumbovertebral bodies, just to the left of the midline. It ends by dividing at the level of L4 into the right and left common iliac arteries. The point where it divides is called the aortic bifurcation. In looking at the branches of the abdominal aorta, we'll begin with the three which arise in the midline and supply the gastrointestinal organs. Then we'll look at the branches that arise in pairs. The three midline branches are the celiac trunk, the superior mesenteric, and the inferior mesenteric. The celiac trunk arises immediately below the margin of the aortic opening at the level of T12. It divides into three branches: the common hepatic, the left gastric, and the splenic. Between them, these supply the liver, stomach, duodenum, pancreas, and spleen. The superior mesenteric artery arises at the level of L1. Its branches supply the small intestine and much of the large intestine. The inferior mesenteric artery arises at the level of L3. Its branches supply the distal part of the large intestine. Of the branches of the aorta that arise in pairs, much the largest are the right and left renal arteries, which supply the kidneys. They arise just below the level of the superior mesenteric artery. Arising at about L2 are, in the female, the ovarian, and in the male, the testicular arteries, which run downward and laterally over the psoas muscle. 4 pairs of lumbar arteries arise from the back of the aorta. Here are the lower 2. They pass behind psoas major, where they branch to supply the back, the spine, and the abdominal wall. Lastly, here's the median sacral artery, which arises from the back of the aorta just above the bifurcation and passes down into the pelvis. Next, we'll look at the common iliac arteries and at their branches. On each side, the common iliac divides into the internal and external iliac arteries. The common iliac artery runs close to the medial border of psoas major. It divides here at the pelvic brim. Here's the external iliac artery. Here's the internal. We'll look at the internal iliac in the next section. The external iliac artery is the main artery to the lower extremity. It runs along the pelvic brim just medial to psoas major and passes beneath the inguinal ligament. Below the inguinal ligament, the artery goes by a different name, the femoral artery. Just before passing beneath the ligament, the external iliac gives off 2 branches, the deep circumflex iliac laterally and the inferior epigastric medially. The inferior epigastric supplies the lower part of the abdominal wall. We'll see where it goes in a minute. But first, we'll add the principal veins of the abdominal region to the picture. We'll start down at the inguinal ligament. Here's the femoral vein, lying medial to the femoral artery as it passes beneath the inguinal ligament. Above the ligament, it's called the external iliac vein. The external iliac is joined by the internal iliac to form the common iliac vein. The 2 common iliacs join just to the right of the aortic bifurcation to form the inferior vena cava. The right common iliac artery passes in front of the left common iliac vein. The inferior vena cava runs just to the right of the midline. It lies on the vertebral bodies from L4 to T12, then on the left crus of the diaphragm. It passes through the diaphragm here to enter the right atrium, as we saw in the last section. The 2 large renal veins join the inferior vena cava at the level of L2. This is the left testicular vein. The right one has been removed. There aren't any veins that directly correspond to the celiac trunk and the mesenteric arteries. The blood that goes out through those arteries comes back to the liver by way of the portal vein, as we'll see in volume 5 of this atlas. The blood from the liver then returns to the main circulation through these large hepatic veins. The hepatic veins are very short. Their number varies. Here there are 3. They enter the vena cava just below the diaphragm. Next, we'll look briefly at the main blood vessels of the anterior abdominal wall, the superior epigastric and inferior epigastric. We've seen that the inferior epigastric artery arises from the external iliac. The superior epigastric artery is the continuation of the internal thoracic. We saw it in the last section. In this dissection, the peritoneum and fascia on the inside of the lower part of the anterior abdominal wall have been removed. Here are the external iliac vessels. Here are the inferior epigastric artery and vein. They pass upward and medially and run up the back of the rectus abdominis muscle. They enter the rectus sheath by passing in front of the arcuate line. The superior epigastrics also lie behind the rectus abdominis. To see them, we've removed the upper part of the posterior rectus sheath. Here's the superior epigastric artery, emerging from behind the costal margin and passing down onto the back of the rectus. Its branches are anastomose with those of the inferior epigastric within the rectus muscle. Now we'll move on to look briefly at the principal nerves of the abdominal region. First, we'll see the nerves that provide the motor and sensory supply to the lateral and anterior abdominal wall. These nerves are continuations of the lower intercostal nerves from T7 downwards. Here are 4 of them. They emerge beneath the costal margin. Here's the 11th rib. Here's the start of the costal arch. the nerves run obliquely downwards and forwards in the plane between the transversus abdominis and internal oblique muscles. The external oblique has largely been removed in this dissection. Next, we'll look at the nerves of the posterior abdominal wall. Most of these are derived from the lumbar plexus, a complex joining and rebranching of the anterior primary rami from the 12th thoracic to the 5th lumbar segment. The lumbar plexus lies behind and within the psoas major muscle. The nerves that arise from the lumbar plexus emerge from beneath psoas major or through it. Here are the subcostal nerve, which comes from T12, the iliohypogastric and ilioinguinal nerves, the lateral cutaneous nerve of the thigh, and the genitofemoral nerve. Between them, these provide sensation to the inguinal region and to the anterior part of the upper thigh. Here are two major nerves of the lower extremity, the femoral nerve emerging lateral to psoas major and the obturator nerve emerging medial to it. The femoral nerve runs alongside psoas major and passes beneath the inguinal ligament just lateral to the femoral artery. The obturator nerve runs just below the pelvic brim and enters the obturator canal. The femoral and obturator nerves are shown in more detail in Volume 2 of this atlas. Lastly, we'll look at the principal autonomic nerves of the abdomen, the vagus nerves, the sympathetic trunks, and the aortic plexus. Here's the aortic bifurcation. Here's the upper part of psoas major. Here's the right crus of the diaphragm. Here's the sympathetic trunk emerging through the edge of the diaphragm and running close to the vertebral bodies down toward the pelvis. Again, here's the right crus of the diaphragm. Here are the divided celiac trunk and superior mesenteric artery. This is a large sympathetic ganglion. It's connected to this smaller one and to several others that have been removed in this dissection. Together, they form the aortic plexus, which distributes sympathetic innervation to most of the abdominal viscera. To see the vagus nerves as they enter the abdominal cavity, we'll look at a dissection in which the stomach has been left intact. This is the stomach. Here's the esophagus. It comes through the diaphragm here. Here are two branches of the right vagus nerve, also passing through the esophageal hiatus. The branches of the left vagus are out of sight, round here. The vagus nerves break up into many smaller branches, which provide the parasympathetic supply to the stomach, the small and large intestines, and other abdominal organs. Now let's review what we've seen of the blood vessels and nerves of the abdominal region. Here's the abdominal aorta, the celiac trunk, the superior mesenteric, and inferior mesenteric arteries. Here are the renal arteries, the testicular or ovarian arteries, the lumbar arteries, the median sacral artery. Here's the common iliac, internal iliac, external iliac, and femoral artery, the deep circumflex iliac, and inferior epigastric arteries, the inferior vena cava, and the hepatic veins. Here are the subcostal nerve, the iliohypogastric and ilioinguinal nerves, the lateral cutaneous nerve of the thigh, the genitofemoral nerve, the femoral nerve, and the obturator nerve. Here's the sympathetic trunk, a sympathetic ganglion, and the vagus nerve. That brings us to the end of this section on the abdomen. In the next section, we'll look at the pelvis.